Okay, you ready?
Yeah, let's do it.
All right. Do you want to just introduce yourself, who you are, what do you do?
Yeah, I'm Blake Davidson. I'm an emergency medicine doc at University of Kentucky. I did an EMS fellowship down in Birmingham, Alabama, and one of our EMS medical directors.
Awesome. Well, thank you. So we want the perspectives of like emergency physicians, both adult and ped, and then trauma physicians, adult ped, and then the blood folks. So we appreciate you taking the time
For sure.
to do this interview. And we value your experience with spinning up a pre-hospital whole blood program in the past.
Yeah.
So you can share some of your insights. So I think we'll start, we've got a list of questions. We'll just go down, if that's okay with you.
Okay.
We don't want to discourage our paramedics from giving blood. In fact, we want to encourage them. Like if they think the patient's hemorrhaging and they're in shock, we want them to give the blood. And I think San Antonio said they have about a 5% over triage rate with that. But also we don't want to just needlessly give blood to people who don't need it. So, and I guess you can talk about some of the indications for giving blood, some of the vital parameters, but how do you think we can avoid giving blood to patients who aren't actually hemorrhaging?
Yeah, I think the biggest thing to kind of look out for is really putting the whole picture together, right? Because the first vital sign to be abnormal in any sort of shock is going to be tachycardia. Well, a lot of the patients that we see, especially initially on arrival, are nervous or in pain, which is also going to affect their vital signs, right? And so to make sure that we're treating those appropriately first before we just jump to give them blood because the patient's tachycardic. The other thing I think we kind of need to be a little bit hesitant on are like from a medical standpoint of like nosebleeds or GI bleeds where on scene, it can look like there was a significant amount of blood loss just because there's blood all over the floor, when in reality the patient hasn't lost a ton of blood. And so, making sure that our vital signs and the overall patient picture looks like that this is actually shock. I think the other thing to kind of keep in the back of our mind is the trending of vital signs. So not necessarily just reacting off the one set of vital signs, the initial ones that patients get, but after we've seen them, evaluated them for a second, got to recheck on vitals and seeing which way that the direction is going.
Oh yeah, I guess one isolated complete set of vitals doesn't mean a lot.
Right. Yeah, it's a lot like, I think we preach a lot of like the same of EKGs, right? And one EKG in isolation doesn't really mean anything. That we need to see a couple to be able to see progression in those situations.
That makes a lot of sense. And I suppose you could also look at the whole clinical picture, so if we've got maybe an incident of hypotension, but the end title's 40, well, those two may not correlate.
Right.
So, good. So trend your vitals, get more than one. And there are, I think at one of the PHQAC meetings, you presented on a case of a patient who had like multi-system trauma, had a lot of fractures and stuff, and had incidences of initial hypotension, but was not hypotensive on subsequent evaluation and readings. And there's this weird situation that occurs to patients who have a traumatic mechanism but don't have any serious bleeding that can sometimes be hypotensive initially.
I'll say, like for myself, I had a trauma, I had a wall collapse on me last summer, and it fell on me. I got up to the patio to be able to like get back on there, and then I passed out. Lost consciousness, was obviously hypotensive and tachycardic, and didn't have any large bleeding. And what I probably passed out from was from a loss of that sympathetic urge, right? Like where I initially had this trauma, had a lot of epinephrine rushing through my body, and then once my body realized I was safe, that stopped, and then my blood pressure tanked, and then I passed out, right? So like, same thing with like epistaxis, people have a lot of bleeding and they see all this blood, and just like when people get poked for IVs, they vagal down and get hypotensive initially, and so that can kind of be something that's on the back of your mind, just making sure that they're comfortable that that initial phase is under wraps, and then start to address the bleeding.
That's interesting.
Yeah.
It's kind of like the, what do they call it, post-rescue or circum-rescue collapse, where people are fighting for their life, and then once they get rescued, they collapse.
Yep. That's pretty much what I experienced.
Interesting.
Yeah.
Now, and in that case we reviewed, I think we decided it probably would have been indicated to give TXA due to the mechanism, the hypotension, all of those things. It wouldn't have been wrong.
Right.
So do you think it's fair to tell our medics that, look at the whole clinical picture, use good judgment and clinical decision making, and if we're never wrong and we never give it to a patient who's not bleeding, we're probably not giving it to some who need it.
Yeah, 100%. I think if there aren't any misses, then we're probably being a little too conservative, and that it's okay to give one or two people blood that may not necessarily need it in that situation. But I think like if patient has a significant amount of blood loss, they have signs of developing shock, and you give blood, you're not going to be faulted or looked at in a bad light for doing that.
Okay, perfect. Yeah, sometimes making that decision quickly, because it's like, well, if we're giving blood, we don't want to sit on scene too long. We want to be moving, so we're trying to make the decision quickly. So there are going to be some.
I think that from how this situation will go is that if the shift supervisors are holding it, and an arriving medics or arriving team gets on scene and sees that there's blood loss and patient has initial vital signs that indicate shock, to go ahead and call for the shift supervisor to come to scene to be able to get that blood on scene as quick as possible. And then if the patient's stabilizes by the time the shift supervisor gets there and we don't need to initiate blood, then that's reasonable. But at least, I think it would be okay in these scenarios, since blood's not going to be on scene, to be able to go ahead and call early to be able to get that response if needed.
Yeah, that's a very good point. And we would want our supervisors kind of screening the calls.
Right.
It sounds like a blood run, go. But not everything's going to sound like a blood run initially.
Yep, exactly.
Do I expect them to go on every epistaxis call? Not really. Those can be handled with some Afrin, TXA, nasal clamping, stuff like that. But if you get there and like they're bleeding, then call for a supervisor. And I guess that would get us into giving blood to non-trauma patients, because some medical causes of bleeding can look bad.
Right.
But maybe we can get hemostasis quickly, and blood isn't needed. So could you maybe talk about some of the medical signs and symptoms and indications for things like GI bleeding, postpartum hemorrhage, and I've got the rest of the list, but stuff like that.
So I think the signs of shock are going to be the same for medical and trauma. I think the thing that I try and key on and try and key our residents on the most is that pulse pressure variation. And so, like I said earlier, you'll get tachycardia for many different reasons, right? Pain, nervousness, just kind of anxiety in general. But the pulse pressure is something that the patient can't really control. And so that's why, for me, trending vitals is extremely important, right? And so you get that initial set of vitals, the blood pressure is 130 over 90, and then you get another set and it's 110 over 100 or 110 over 90, like that pulse pressure is narrowing a little bit more. That to me indicates that this person is actually developing shock from whatever hemorrhage that they're suffering from. I think the amount of blood loss on scene isn't a great indicator of the need for blood. So I would hesitate to see, like if you come into a scene and there is a lot of blood on the floor, to keep it in the back of your mind, but don't necessarily use that as like, well, there's blood everywhere, so I just gave blood.
It's hard to estimate the amount.
Very, very hard. Yeah, and I feel like, and from my standpoint, like I see people take pictures of their blood all the time and bring it in, and I see them like, oh man, that's a ton. And then you actually get their labs back, and they really haven't lost too much, or they end up not ever needing a transfusion. So I would keep that in your mind. Obviously, see that they've lost blood, but not use that as like the sole indicator. And much more so, like that pulse pressure is something that I would look at pretty closely. And then the shock index of, is their initial shock index 0.6, and now it's 0.9 on our second set of vitals. Those two in combination can help me make that decision.
And I think with the pulse pressure, we're looking at the systolic getting closer to the diastolic, so it's narrowing.
Yep.
And then with the shock index, what I tell people is, like, I don't like having to do a lot of math when I've got a sick patient, but when that heart rate gets over the systolic,
yes,
then you know it's greater than 1.
Right.
That shock index is greater than 1.
Yep.
So start thinking that something's going on.
100%.
So with GI bleeding, we can have upper, we can have lower. Any pearls on that? Because I foresee this being an indication when we're going to give it.
Yeah, especially with our patients in Kentucky. I think one thing that I will say, no TXA in GI bleeding. I think that's pretty well established that it doesn't really help. So no TXA. And for them, a lot of these cirrhotics are going to be hypotensive just from being cirrhotic. But I think that if you have evidence of significant GI bleed, if they've vomited a bunch of blood and they are tachycardic and have an air pulse pressure, I think you can give it to them. Give them a unit of blood. Patients are going to be anemic at baseline anyway, and so I don't think that transfusing them would be a bad idea.
Now the esophageal varices patient, that is kind of straightforward.
Yeah,
like it's very evident they're vomiting copious amounts of blood.
Yeah.
But what about lower GI? Do those patients commonly need massive transfusion?
Not typically. And the only time that the only time I've ever actually done MTP on a lower GI bleed is it's incredible, like an incredible amount. Like you will know when you need to give blood for those patients, like they are just actively hemorrhaging out of their rectum. But for the most part, the lower GI bleeds, we don't necessarily have to transfuse.
Okay, perfect. I mean, because that's mixed with stool, it's dark, and it's like it can get smeared everywhere, so it might be impressive to look at.
Yeah.
But
most of those are, and that's like an accumulation through the GI tract too. So, and the only ones that I've transfused in the emergency department, like emergently, are from like ruptured AVMs or ruptured arterial bleeds that's bright red blood coming out of the rectum, and something that is, like I said, you'll know when you need to from that standpoint.
Perfect.
Yeah.
That's very helpful to know. And then I feel like patients who have a fistula that ruptures, obviously our priority is going to be stop that.
Yes.
And that's what I'll tell my people and every other EMS provider is if there's external bleeding that's compressible or tourniquetable or wound packingable, do that first.
Yeah,
right?
For sure.
Would you agree?
100%. I think this is another kind of like, pseudo trauma / medical with these bleeding fistulas that are going to need transfusion because this is essentially an arterial bleed that can be very significant in patients that have a tendency to bleed more because they're on dialysis, have renal disease, and so then they probably are baseline anemic anyway. So these patients are like ideal candidates for transfusion if they do have a true significant bleed from the fistula. Number one is treat it like trauma from a bleeding standpoint, pressure, tourniquet as needed, and then assess the patient's vital signs and transfuse as needed from that standpoint.
Perfect.
I think the number one, we talked a little bit about the March protocol, and that's how I assess most traumas and how we have our residents assess traumas as well, is that, bleeding, a lot of the things that happen in trauma can kill you, but bleeding and airway are probably the type two, the first two. But the thing that we can control fastest is going to be bleeding, right? So tourniquet up, get the tourniquet, control the bleeding, and then assess the patient.
Perfect. Yeah, and I think it's bleeding, airway. Well,
massive hemorrhage, airway,
pneumothorax.
Yeah.
But I've heard someone say number one, number two, number three causes peri-arrest or arrest traumatically injured patients is bleeding. So
Yes.
always think bleeding.
Yep, 100%.
Now we have blood, so there are recent surgery considerations, recent like surgery or recent urological surgeries. I think I've anecdotally seen this. Patients recently have surgery, and then it's evident that something has dehisced or they're bleeding.
Yeah, these are a little bit more challenging, I think, from my standpoint of how far out are you from surgery? Because if patients have had some sort of abdominal surgery and then a week out, they're starting to get sick. They call because they're febrile and hypotensive, or just because they're hypotensive, and you get there and they've got a little bit of a fever. Like, is this a deep space infection? Is this like a infectious surgical complication, or is it bleeding? So I would say without like active evidence of hemorrhage, then I would treat it more so of infectious etiology. But if they have like a open wound dehiscence with bleeding, if they've got a recent urologic procedure and they've got blood in their Foley catheter and they're hypotensive, then I think those would be more of an indication for treatment. Abdominal operations are going to be a little bit more challenging unless their wound is open, because it really kind of depends on the timeline of their surgical course, if that makes sense. Patients that have come in for a surgical operation and were discharged like an outpatient surgery, discharged same day, and then a day later they have severe abdominal pain, that would make me more likelihood that, or think that they have a higher likelihood of bleeding.
So you're talking very recent.
Very recent, yeah, very, very recent. I think the other patients that would be high risk, surgical patients that would be high risk of any sort of vascular patients. So patients that have had a recent heart cath, and you look down and their FEM site that they did the insertion point at is massively swollen. Their leg is swollen. We actually just had a patient that had a vascular procedure done and came back in. His leg was monstrous, and they had put him on Lovenox post-operatively to be able to go home with, and he had a ton of bleeding into his thigh.
Wow.
And had a hemoglobin of 4.6.
Wow.
So those patients, one of the biggest areas that you can bleed in your body is your thigh, and so those types of patients, any sort of femoral artery access or vascular procedure is one I would be a little bit more not cautious about, but aggressive in treating for transfusions.
So very good points, very good pearls. And then, obviously, a recent surgery procedure would be a tonsillectomy.
Yeah.
So this is pretty common. Like, we give nebulized TXA for post-tonsillectomy bleeding.
Yep.
So how, I think, is it just the scab sloughs off and they start bleeding from that?
Sometimes it's just they've got significant oozing, or it can be it could be an arterial bleed that just kind of, like you said, initially had some stabilization. Patient coughs or spasms down, and that clot burden breaks off, and then the patients start to bleed. those can be very, very challenging to control, and they can bleed a lot and cause a pretty significant amount of hemorrhage. So those are another subset of patients that I would be a little bit more encouraged to give a unit if they're showing signs of shock.
Yeah, I mean, I think a lot of people die from post-tonsillectomy bleeding.
Yeah, the problem with those is that they are okay until they're not, and I say that in the kind of a way of if they go downhill, they go downhill really quickly, and so I think I'm being a little bit more cautious on those.
There's a good case on the pit. I don't know if you started watching that.
I tried to watch that show, and it gives me a little too much anxiety, and I feel like I'm at work, so I can't watch it anymore.
It is kind of tough to watch.
Yeah.
Now, ruptured ectopic pregnancy. So how do these patients present, and when would you give blood to that patient?
These are going to be difficult in the pre-hospital setting unless the patient tells you that they have had a positive pregnancy test. And the reason I say that is because most of the time they're going to present with severe lower abdominal pain. And it's a patient that looks horrible. They've got really, really bad abdominal pain. It's localized to one area. They're inconsolable, and they show signs of shock. Now, I think the problem with that is that they can have those with many things like ruptured appendicitis or ovarian torsion or some sort of GI issue that may be going on. I think one benefit that you guys may be implementing is ultrasound. So you get that patient that has a young patient that's got severe lower abdominal pain, they're showing signs of shock. You do a quick fast on them and you see blood in the abdomen or you see fluid in the abdomen, then that patient has presumed ectopic pregnancy until proven otherwise. And so that would be the indication for blood in my case for those in the pre-hospital setting. I think if you don't know they're pregnant and you don't have the ultrasound, it'd be a little bit hard to justify because there are other things that could be causing that patient's clinical picture. But I think if you don't know and you're able to throw a quick ultrasound on them and you see blood or you see fluid in the abdomen, then that is an ectopic pregnancy until someone sticks a camera and tells me no.
I like that. I was thinking about ultrasound when we were talking about recent surgery patients, knowing if they're actually bleeding or not. So.
Yeah, for sure.
Good. And
the caveat to that is if you got a cirrhotic patient, if you see fluid in the belly, that doesn't always mean blood.
So will they often have like a positive Morrison's pouch?
They'll have a positive FAST, and it's just because it's ascites. And so normally if you know that this patient is cirrhotic, like we just call those indeterminate FAST because we're not sure where that fluid is coming from.
That makes sense.
Those are challenging.
So do they have to have obvious ascites for that?
Not necessarily, because some people have a small amount of ascites that you may not be able to see on physical exam, but then you put a probe on their belly and they've got a little bit of fluid hanging out there.
So history of liver failure, consider that cirrhosis.
Yep.
Perfect. And then ruptured aortic aneurysms. So ruptured aortic aneurysms, or maybe it'd be more appropriate to say ruptured aortic dissections.
Yeah.
And so sometimes, I mean, it's not infrequent that we do interfacility transfers on patients with diagnosed leaking aortic dissections, and I've transported one who has ruptured before, and the same can be true for recent surgical patients who we do an interfacility transfer, and our standalone ER has very limited blood. And they can exhaust their supply, just like 2 units of red blood cells. So I could see that being an indication as well. But what are your kind of signs and symptoms of a ruptured aortic aneurysm, and when would you give blood to that patient?
These are going to be a little bit more challenging because the blood pressure management of these patients is a little different than our other standard patients. We're a lot more apt to do kind of your permissive hypotension, right? Where we don't want these patients to be significantly hypertensive because that's just going to encourage bleeding from their ruptured aorta, which can be challenging to manage. And I think that, for them, sometimes our goal is to have a systolic blood pressure of about 90. And so I think those are going to be difficult and be done on like a case-by-case basis. And I think most of those are going to be interfacility transports of a known diagnosis, unless you have ultrasound capabilities and can see like this is a ruptured aneurysm. But if you have a known diagnosis, and that's when I would talk with the sending physician to see if they have labs back, to see if they have an initial hemoglobin of what the patient was sitting at, what their goals are, and then if the patient starts to become more hypotensive en route, then I would give a unit at that point.
That makes a lot of sense. Yeah, I know with those aortic dissections, I often try to keep the systolic low and then keep the heart rate really low too, because each beat can dissect it further. Right?
Yeah, and it depends on what type of dissection, whether it's kind of up higher in the chest or whether it's down in the belly. The type A versus type B dissections, your parameters are a little bit more loose for the type B dissection because it's not as close to the heart. But the type A dissections were really stringent and strict. And so I think really talking with, if it's a interfacility transport, talking with the sending physician of saying, well, what type of dissection is this? What are your blood pressure and heart rate goals in order during the transport?
That makes sense. And type A can dissect into the coronary arteries. You can get STEMI from it.
Yeah.
Cardiac tamponade.
Yep.
Also, right. And then type B would be the common, almost like kidney stone presentation, back or flank pain radiating to the groin.
Yep.
And now with checking, everybody checks, blood pressure in each arm or leg, but I think that's not very specific, is it? I think now they recommend like pulse or no pulse is the most specific.
Yeah, I've seen it happen where there's a little bit of blood pressure variation, but it would be one of those things that is specific but not sensitive, if you want to get into like the technical terms, meaning that it's not going to catch all of them. There are going to be many that have a negative one and still, or negative like variation and still have a dissection. But if you see a variation, then in the right clinical scenario, then your likelihood is going to be like they have this.
Okay.
If that makes sense, right?
Yep.
And it's going to be most commonly present of a right upper extremity being lower than your left upper extremity if it's a type A dissection.
Okay.
That's because the branch that feeds the right arm, the artery that feeds the right arm, is the first branch off the aorta, and so you're going to see variation in the right arm before you are going to see the left arm.
More likely to see it lower in the right arm than the left.
Right.
Okay. Perfect.
Yep.
It's very helpful. And then postpartum hemorrhage.
Yeah.
That's something that could be kind of obvious, right?
Right. Yeah, and that's going to be one that from a non-traumatic standpoint, this is where we're going to save the most lives, I think. All right. This is something that can be extremely, patients can lose a significant amount of blood, not only from like childbirth, but now from this massively bleeding uterus that is happening in front of you. And so I think really early, this is one that I feel like all the shift supervisors should be dispatched to all of those calls, postpartum hemorrhage, and being able to get on scene, getting blood early and TXA early in those patients, and doing your uterine massage as possible, or whatever else you have on.
So don't forget a uterine fundal massage. Don't forget that.
Right. Don't forget that. Still do that. Absolutely. Still do everything that you normally would, but while you're doing your normal process, making sure that we're getting blood set up, TXA administered, and the patient to the hospital quickly.
Perfect. I don't know that we have TXA specifically in our protocol for postpartum hemorrhage. Is there evidence for that?
Yeah, that's like some of the best evidence for TXA. It's a trial called the Women's Trial, and so postpartum hemorrhage TXA is absolutely something that is part of my workflow.
Perfect. Yeah. So it's good to know.
I would say it's some of the best like TXA data.
Right.
So, as good as TXA
That's
data
how
can
it kind
be.
of got started, right? With,
Yeah.
with postpartum.
Yeah, they really tried it for postpartum, and after they got out of the trauma field, so they really tried it for postpartum hemorrhage. So it's I would say it's pretty good data. It's not the strongest data out there that I've ever seen, but as far as like from the TXA world, I give it in postpartum hemorrhage.
Perfect. Do you get the same dose that you
2
give
grams.
to trauma? 2 grams. Okay. Nice.
Well, I guess the 1 gram over 10, and then the 2 over the next, whatever.
Yeah. I know a lot of people are transitioning to giving 2 grams off the bat to start with. So.
Yeah, I say that's a little bit of variation. I would be fine with 2 grams off the bat, but whatever your
Everyone has different protocols
exactly
for it. Now let's talk about giving the blood. I know everybody wants these bilateral large bore IVs, but like what I tell my people is I don't want you sitting on scene forever trying to get large bore IVs when you can do bilateral humor IOs or bilateral any IO. Now is there a minimum size that you can't push blood through? No.
If you got access, you can give it. Then there's not really a preferred site. Obviously the 16 gauge in AC would be phenomenal.
Yeah.
But I think we all know, anybody that's been in the pre-hospital setting knows that that's not always the easiest to be able to do. But if you've got an IO, is that the only type of access that you have, then you can give blood through an IO. And that's fine. Maybe a little bit more difficult. You may have to just squeeze it in, but you can absolutely do that. So I don't think there's a minimum size. Access is access, and initiation of blood starting earlier is better.
Perfect. Now we were told by the San Antonio folks that a lure lock, we use a lot of extension sets with lure locks. They said that can hemolyze the blood, so take the lure lock off.
Yeah, and it can slow the flow. It slows the flow rate down quite a bit, right? So you want to hook these directly up to the IV without the hep locks.
Perfect. Yeah, you can start at 16 and then you put a lure lock on it, and then you're just narrowing the size down.
Absolutely.
Perfect. Yeah, and we're gonna use a pressure bag on our blood and use a hand pump to get that blood in. Now, when it comes to just giving the blood, we've kind of already talked about doing the other things also, like walk and chew gum at the same time.
Yeah.
Stop the bleeding if you can. But let's say we're ready to give that blood. At what point do you give the TXA and the calcium?
I would give TXA. If I'm giving blood, I'm probably going to give TXA. Okay. And the caveat to that is not in GI bleeding.
Not in GI bleeding.
But otherwise, in all the other pre-hospital settings, trauma, epistaxis, postpartum hemorrhage, if I'm giving blood, I'm going to give TXA.
Does it have to be before or after, or whenever you can?
Whenever you can. I think putting restrictions on it too terribly much would discourage use. So I think if it's something that you've gotten on scene and you got access and the patient's bleeding like crazy and you're like, all right, I need to give them blood, and then en route, like 10 minutes later, I haven't given TXA yet. I think it'd be fine to go ahead and give TXA at that standpoint, because the patient theoretically, especially if it's intra-abdominal bleeding, like we probably haven't got blood control, right?
Very good point.
So I would go ahead and give a unit at that, or give the 2 grams at that point.
Perfect.
From a calcium standpoint, after your second unit of blood is when I would probably start thinking of going ahead and giving calcium. So if we've got 2 units on the supervisor truck and for some reason the transport time has allowed us to be able to give 2 units, I would give calcium as you're infusing that second unit.
Okay, perfect. Well, I think we can discuss this later, but I think our protocol is going to be calcium with the first unit.
Okay.
I think, now you got the trauma triad of death. Now people are calling it like the tetrad or the lethal diamond to include calcium. So I know giving it probably might not be giving calcium probably wouldn't be a priority, especially with just 1 unit, but kind of if you can give it. Because hopefully if we're giving blood, that means the patient's probably going to need more blood.
Exactly. exactly. And I think that that's like a part of our like MTP protocol is after the second unit. That's when we're giving it. So I think go ahead and get it on. If we're giving multiple units or we're giving blood, the patient's probably going to need more. A gram of calcium isn't going to hurt the patient.
Okay, perfect. And calcium shouldn't give it in the same line as blood.
Right.
But now TXA, I've heard different things about. I've heard you can and you shouldn't.
Yeah, I can double check with our pharmacist on that, but I'm pretty sure you should be able to.
Okay, I think Kotze says you can. If it does not, then I will cut this out. Okay? But you can give TXA in the same line as blood.
Okay.
Perfect. Now, lastly, if we have to transport a patient to a facility that's not UK, who's not familiar with uncross-matched blood, what should we tell them so that they're aware this patient has O positive, has been given low titer O positive blood?
Yeah, I mean, I think it's just that. I tell them, just like your standard report, if you tell them what drugs you've given, and what times, it'd be very similar process of, like when flight teams bring patients in on blood, they pretty much tell us as a part of their normal report, right? Is that we started blood at this time through this access, and it is, O positive, right? And I think most physicians should be pretty familiar and understanding that's of like what that means and how to be able to manage that. So I don't think any necessarily excess information is needed other than just kind of obviously access, start time, and indication.
Okay. And any transfusion reactions.
Exactly, yeah. And so like any sort of change in vital signs. So, we arrived on scene, patient was hypotensive with evidence of bleeding. We started blood. Our repeat vitals are now this after blood transfusion.
Perfect.
And so to make sure if we've got a response or not.
Okay, wonderful. Any other pearls or recommendations for the folks?
No, I'm excited. I'm excited to see this work. And I think, again, the biggest thing that I think whenever we have this early is to be cautious, aggressively cautious, right? Is that I think calling for a shift supervisor early and signs of hemorrhage, and that we get them on scene and have the blood available, but then using our clinical scenario and patient vitals in order to be able to actually indicate, does the patient need blood or not?
Okay, love it.
Cool.
This was great.
Thanks, bro.
Thank you so much.
I appreciate it.